if we're on the topic of McKenzie and say any listeners want to, potentially learn more about it and getting introduced to something that is pretty straightforward and a classic case. While we're on the topic of McKenzie, I'm a fan of it. You're a fan of it, of course, with it has its limits, but I think it's worth talking about so people can be equipped to utilize it, right? So briefly, let's kind of close out McKenzie conversations just by educating a little bit on it. So you used the term derangement, things like that. Could you briefly describe what a derangement is?
McKenzie's derangements a little bit of a unique presentation of how they describe that. So usually that'll be kind of any classification of we're usually talking about discs, and they had different theories. McKenzie, they don't exactly know what's going on, and frankly, they don't really care because the clinician outcomes and the outcomes of treatment is so well documented, so well researched, and if you actually do find DP, the prospect of getting better is so high. And there's so much research about that, but we don't know exactly what's going on when it comes to the tissue. You'll hear some with like the jelly donut theory, where the disc material is being pushed, that you have the nucleus pulposus and you have the annulus fibrosus around it. And that nucleus pulposus is being pushed in one direction. And the theory is, we're sitting all day, we're flexing all over, or flexing, bending down, picking things up, or driving. We're always in a flex position, which can put compression, flexion compression on the front part of the disc, which is pushing the material back. And then by going into press ups in this case with a posterior lateral, by going into that extension, you're theoretically pushing the material back in. That's one theory that you'll often hear. Is that exactly what's going on? Unfortunately, we don't know the answer yet, but we do see such great results with it. But going into directional preference would be the movement that gets the patient out of pain or centralizes them. We're really looking for centralization. That's the biggest thing we're looking for. And again, that's taking those symptoms from distally to proximally out of the leg, out of the hip, back midline to the spine. So we're looking for directional preference. Most of the time, that tends to be extension. Next, we'll usually get flexion. And then the least common we'll see is flexion. But how we do that is usually we'll just go through a set protocol. Most people start standing. Sometimes, depending on the case, you will have to switch that presentation. Sometimes, like I was saying, how I started with this past patient was standing in extension, kind of knowing his history. I already kind of put together that that would be the DP for him. But sometimes you'll have some where it's a little bit more tricky to find out, and you may have to extend them, 10, 15, 20 reps to figure it out, flex them, or do lateral side glides. So it really depends on the person, and then taking the time, as you said, it's just so important that you have time and make sure to take that time to really try to figure out their directional preference to hopefully get to some centralization.
Hmm.
And what we're looking for is you also get, as I was saying earlier, peripheralization. That's what we're trying to avoid is those symptoms going farther into the leg or intensifying.
Hmm. Nice. I think it's a very, very solid explanation. And I just to add on to the concept of kind of the mindset of McKinsey and even the shift in the profession and field as a whole to kind of step away from the patho-anatomical approach and just to kind of look at functional outcomes, I think there's a big shift in that direction, which I quite frankly agree with. To some extent, there needs to be some subjectivity measures so the patient can understand, hey, I am getting better because they may care more about their pain than functional outcomes, but that's where education comes in, right? So again, that can be a topic for another day. But that being said, though, I happen to enjoy nerding out about the mechanisms at play. And while we do not know, it's cool to talk about. So whether that's the disc theory, which many McKenzoids probably still subscribe to that from my dialogue with them. And again, whether it's that or like Cody DMAC, he's a big proponent of the vasonervorum and the in-range repetitive loading kind of pumps the blood and kind of the pain. I guess the theory is there's a pooling of the blood causing irritation and sensitivity to the nerve that supplies the nerve. So that's causing pain. And the repetitive loading kind of pumps the blood out, so decreasing almost that ischemic compression there on the nerve itself. Or kind of what I think is going on more times than not is actual like joint receptors, like the type 3 joint receptors within the joint. When you get to in range, those are stimulated and it can have a bit of an analgesic effect to calm down pain a little bit and increase range of motion as well. So when we talk about derangement, that's, the most common classification within McKenzie. And derangements, what's present, there's an obstruction to movement. Pain is variable, it kind of dances around. That's kind of a classic presentation of it. When you're palpating and find a joint restriction, you know, getting to in range, moving it around, see what the functional and pain outcomes are, and see if you're moving the needle. It's to me really effective way to kind of move the needle on your pain or functional audits, and seems to be really effective from the times I've used it. And so it's cool to hear a case where you're seeing some good outcomes with it as well. Anyway, it's neat to discuss the mechanisms. I don't know if anyone out there is also a nerd about it.